Patients do not like having a drill into their hip bone. It hurts, it's painful, and they really don't like it. But I haven't run into a patient yet who is not happy about having a little bit of fat tissue removed from their body. It's very popular with the patients. It's easier to harvest, it's less painful. I joke in many of my lectures that, adipose harvesting for stem cell procedures is the only procedure in the history of medicine where the donor site actually looks better than when you started. If you take a donor site for a skin graft, you have a big scar. If you have a donor site for bone marrow, you have scar tissue, and there's no cosmetic improvement. We're not doing this for cosmesis. However, it is the only donor source in the history of medicine where the donor site actually looks better than prior.
Hello there. In this episode, I have the one and only Dr. Randy Miller. Now, if you haven't known Dr. Randy Miller, you should, because he is one of the pioneers in regenerative medicine. And I've known Dr. Miller since I started doing regenerative medicine, and one of the plastic surgeons that really refined my fat harvesting technique. So Dr. Miller is board certified in plastic and reconstructive surgery and practicing currently in Miami, Florida. He is also certified in American Board of ENT as well. If you're not aware of that, I didn't know that until recently. He is one of the pioneer and the expert in regenerative medicine, and is one of the founders of the American College of Regenerative Medicine, ACRM. And today we have him in this episode so he can share his wisdom on regenerative medicine. So welcome, Dr. Miller.
Thank you, Anne. Pleasure to be here.
Let's talk about regenerative medicine from a plastic surgeon ENT perspective. How is your evaluation of a patient that needs regenerative medicine with your unique background of ENT and plastic surgery different than like somebody like myself who is in interventional pain?
Sure. Well, I think we started working with fat transfer. It was Dr. Sidney Coleman in the 1990s who really taught us about structural fat grafting. And we learned as we were doing cases at MD Anderson, there were patients with horrible radiation fibrosis and real damage to the tissue. And we were injecting adipose tissue for the purposes of reconstruction. We saw that all of the radiation damage was being reversed and cured, and the skin was becoming soft and supple and much more comfortable for the patients with less pain. But at that time, we didn't even know that there were stem cells in adipose tissue. And then in 2001, it was a landmark discovery identifying mesenchymal stem cells in adipose tissue. And since then, we have applied it to many different applications. And we also understand that mesenchymal stem cells are the source of not just exosomes, but EVs or extracellular vesicles. Exosomes are just a small part of all of the vesicles and EVs that are out there in the circulation that are provided to the tissue from mesenchymal stem cells. Now we're using it for many different applications for orthopedics, and interventional pain, and many different applications related to the magic of mesenchymal stem cells and EVs. If I could just for a minute give a little plug for my hashtag, we say fat is where it's at. It is the primary source. It is the best source. It's much better than bone marrow, much better than perinatal tissue. And fortunately, because it's adipose tissue, there's no shortage of that. So we have an unlimited supply of donor material.
And patient loves it when you said, I'm going to take some fat from you to help you heal.
Absolutely. Yes. As a matter of fact, we're doing a clinical trial right now with plantar fasciitis, working with the podiatrist for the Miami Heat, and we're using adipose tissue and also combining that with platelet-rich plasma. We found that combination is very efficacious as well.
How does fat combining with PRP, how does this kind of work? Can we just put the fat in there alone, or does it need a little bit of PRP to stimulate that?
The important thing to understand is that there are no stem cells in platelet-rich plasma and PRP, but it has a lot of EVs, not just exosomes, but a larger vesicles, which are really, kind of included in the term secretome, which are all the EVs. And so there's a great synergy between adipose mesenchymal stem cells and all of the growth factors and cytokines and chemokines contained in the EVs from platelet-rich plasma. So they're tremendously synergistic, and we see great results with that. It really depends on what you're doing with the adipose tissue. If you're trying to reconstruct a breast and you need a lot of volume, you can only get about 7 cc's of PRP from a patient. And if you're going to combine that with hundreds of cc's of adipose tissue for like a bilateral breast augmentation or breast reconstruction, it's not really as powerful a synergy as if you are injecting into a joint for orthopedics or podiatry and other things. So we like to use it. It's an ideal combination, and we use it a lot, but it's basically a volume related situation. So with adipose tissue in general, we're getting tremendous regenerative activity. Like, for example, as Patrick Tonard and Alex Verpeel, pointed out from Belgium and really discovered that we could take nanofat, which is concentrated stem cells without really much adipose tissue, injecting that into the lower eyelids to get rid of dark circles under the eyes. So for those cases, we're not really using PRP because there's a very limited volume of nanofat to go into the lower lids. So it's condition specific. It's an ideal combination if you have the right ratio for the right indication.
What is nanofat and what is microfat, and just generality? I know they can be a little, sometimes they use both. The generalities of when and where to use.
Yeah, it's an excellent question. So the parcel size of nanofat is 500 nanometers or less. The parcel size for microfat is 1 micron or less. So basically, we're using nanofat for the regenerative capacity, and we're using microfat more for the structural capacity and for volume change and for filling. It's not to say that the microfat doesn't have some regenerative capacity, because it does have a huge number of mesenchymal stem cells, which then release exosomes into the tissue that it's being transferred in. But the misnomer is that there's really no fat, there's no adipose tissue in nanofat. It's a very catchy term, and it's really caught on, and I think the public understands it and the doctors really like it. But it's important to point out that nanofat is basically a concentration of mesenchymal stem cells from adipose tissue without really any adipose tissue itself. It's mostly just the stem cells, whereas microfat is the adipose tissue which contains the stem cells, but there's more structural component for that.
Does it need PRP with it, or most of the time it doesn't?
It's not essential. We have been using it a lot in orthopedics, combining nanofat and PRP for those types of procedures or interventional pain procedures, and to get rid of scar tissue. We've seen fabulous results with scar tissue melting away. As a matter of fact, at the Regenerative Medicine Summit that's going to take place in San Diego in July, I'll be lecturing on the use of nanofat and PRP combined autologic material to the treatment of mature scar tissue. And we're actually submitting a publication right now to our main plastic surgery journal, which is called PRS, or Plastic and Reconstructive Surgery, where we have a huge series of patients where their scar tissue has completely melted away. And, medical students these days are taught that scar tissue is permanent. and there's no treatment for it, only maybe some injection of steroid, which destroys the tissue. And we have great documentation that medical information is incorrect. And now they need to change the teaching in medical schools and change the textbooks to show that you can use regenerative medicine to dissolve scar tissue and cure these patients of their severe scar deformities.
I'm looking forward to that lecture. So on that note, how is fat compared to bone marrow?
In bone marrow, there is less than 0.01% of the bone marrow aspirate are mesenchymal stem cells, less than 0.01%. And that's published, and that's scientific data. If you harvest adipose tissue in 1 cc of lipoaspirate, you have over 300,000 mesenchymal stem cells in just 1 cc. And so that's why adipose tissue has become the workhorse for all of these regenerative medicine therapeutics. Also, what's very important is that this mesenchymal stem cells are found in the perivascular tissue. So each adipocyte, each fat cell has its own capillary. Okay, so there's just a ton of pericytes or mesenchymal stem cells in the perivascular tissue that goes to each adipose cell. In bone marrow, there's no tissue, it's a space. And so you have to scrape the walls of the space to get a very, very small yield of mesenchymal stem cells. So I think that in the early days, the most of the work was done in regenerative medicine with bone marrow because we didn't even know that there were stem cells in adipose tissue. But now that we've identified that, adipose therapeutics and the quality of the tissue and the source of mesenchymal stem cells is so much greater that's why it's really catching on and becoming very popular and much more efficacious.
It's easier to harvest, honestly. It's easier to harvest fat.
Yes, it's easier to harvest. And also, patients do not like having a drill into their hip bone. It hurts, it's painful, and they really don't like it. But I haven't run into a patient yet who is not happy about having a little bit of fat tissue removed from their body. So it's very popular with the patients. It's easier to harvest, it's less painful. And I would say, I joke in many of my lectures that, adipose harvesting for stem cell procedures is the only procedure in the history of medicine where the donor site actually looks better than when you started. So if you take if you take a donor site for skin graft, you have a big scar. If you have a donor site for bone marrow, you have scar tissue, and there's no cosmetic improvement. We're not doing this for cosmesis. However, it is the only donor source in the history of medicine where the donor site actually looks better than prior.
I totally would agree with you on that. And my prefer is fat too, because I've never heard anyone say, "Oh, I don't want you to take fat from me, to do this."
Yeah.
Can you take more? Can you take it out of both sides?
Yes, and you see, that's the question. And we're doing these procedures for regenerative medicine, and the patients say, "Can you take more fat?" And we say, "Well, we need to leave it in there because what about your other knee? Or what about your other elbow? Or what about your other hip joint?" So, the patients are always encouraging us to remove more fat. But we have to be careful. In a patient who has a lot of adipose tissue, that's not a problem. And sometimes we will actually combine that with liposuction. But for those patients who are thin and don't have a lot of adipose tissue, we really want to be conservative on our harvest because they already have a history of osteoarthritis or neurogenic pain. And we want to have more fresh, healthy donor tissue that contains a lot of mesenchymal stem cells.
What are these mesenchymal stem cells in fat? What do they do that is the regenerative part that is so good that we're seeing this remarkable improvement in our patient?
Well, the stem cells, for example, in bone marrow are called HSCs, which are hematopoietic stem cells. And hematopoietic stem cells are for regenerating blood. hematopoietic. Mesenchymal stem cells are the stem cells that are responsible for the regeneration of connective tissue, for bone, for cartilage, for nerves, for skin. So that's really the magic of mesenchymal stem cells. And we used to think that it was just a mesenchymal stem cell that would dock to the tissue and then have its effect. But now we found that the mesenchymal stem cells actually secrete a number of EVs, or extracellular vesicles, including exosomes, and that those EVs then go to the target tissue and unload their cargo. So even if the half-life of an EV is maybe less than an hour, we see the regenerative capacity occurring continuously for years after the actual therapy itself. So that's really the magic of mesenchymal stem cells. It's really because those are the stem cells that are capable of regenerating all of the connective tissue, not blood, but connective tissue that we're looking for in both orthopedics, in interventional pain, in reconstruction, curing radiation damage, closing wounds that are intractable to any kind of hyperbaric oxygen and that kind of thing. So we're seeing, miraculous results with the adipose-derived mesenchymal stem cells.
Wow, I love the way how you explain that. So if a physician that is interested in finding out more about how to integrate regenerative medicine, and let's say, let's say, somebody that does pain management is interested in learning about this, how would you advise that doctor to start learning about regenerative medicine?
First, we have published a textbook recently called Stem Cells and Regenerative Medicine that I published with Dr. Marks, who was the original describer of platelet-rich plasma. And we have lots of information in that textbook. We also developed an internet portal for peer-reviewed, accurate stem cell information with the blessing of the NIH and the FDA. And you can log on to stemcellreference.com, and that can give you a lot of information on current conferences that are coming up, connections to PubMed, so you can view the medical literature. And it's a team of international experts, scientists, regulators, and clinicians from all over the world. And this internet portal now has thousands of unique visitors every week from 5 different continents and 150 different countries. And we developed that because there was really nowhere for patients or doctors or scientists or people in the industry to get accurate information without some kind of an advertisement. So this is a peer-reviewed reference source for that. And then also, the Regenerative Therapy Summit is coming up in San Diego in July. I consider it to be the center of the universe for adipose therapeutics. And it's just, the incredible faculty from all over the world, very experienced faculty. And there's a lot of ability for the attendees to interact with the faculty. So there's lots of one-on-one with lots of questions being answered. And also in the exhibit hall, the hand-selected top vendors are there. So all of the equipment and technology you need to implement adipose therapeutics in your practice is right there in the exhibit hall. And you're not going to find vendors that are distributing or promoting equipment or technologies that are not of a high quality. So everything is very hand selected and, really just top of the line. So I think that is a really the best way for anyone, whether you're an expert in regenerative medicine or you're brand new. That conference is really geared towards anyone who's interested in adipose therapeutics. And it's not just clinicians, there are scientists lecturing as well. So we're, and people related to stem cell regulation. So there's a lot of information on what you can do and what you can't do, being compliant with FDA regulations. So I would highly recommend the Regenerative Therapy Summit.
Absolutely, and you're right on about that. I was amazed at the expert speaker there and the variety, really all over the world. Honestly, and all in one place, and how accessible they are to discussions and for questions. Tell us about the lab. There's one thing about the summit. It's happening on July 30th to August 2nd, but on the last day is the lab. Tell us about the lab. It's a very unique experience.
Yeah, so that's going to take place on the campus of the UCSD Medical School, which is the University of California, San Diego Medical School, in the anatomy lab. It's called the Center for Innovations in Surgery. And we're going to have cadaver dissections, and we're going to teach all of the attendees regarding the techniques for adipose harvesting, for the creation of microfat, for structural fat grafting, for the creation of nanofat, for regenerative capacity. So it's a fabulous opportunity for the attendees to get a hands-on experience. And, you can watch videos and you can read books, but there's nothing like doing it yourself with your own hands. And it's very nice because it's geared for everyone. If you're a brand new beginner, there's, stations for that. If you're super advanced, there are stations for that. And again, that the same world-class faculty that will be there for the lectures are also going to be there for the cadaver lab, which will take place on Sunday. So I think that's a big part of the summit as well. And I'm glad that you mentioned that.
You really get to see them at work doing their magic, training you, and just just seeing how they hold a cannula or their approach to the procedure in itself. It works more than even the didactic session, because you get to see and do hands-on, and they will kind of show you their pearls and their approach as well. I mean, last time I saw you at a cadaver lab, I learned something from you as well.
I learned something from you too, and then the other thing that's really important is that we're showing how to use single-use disposable instrumentation. And that is very important. We started a long time ago saying that needles and syringes can't be shared. That's obvious. And then we started to transition to surgical drapes that were material, and they were being washed in the laundry and never really clean. And then we transitioned to paper drapes. And now if you go into the hospitals and you go into the intensive care unit, you'll see that the bronchoscopes are single-use disposable. Like they don't want to sterilize. And these are, optical equipment, that they're really transitioning. So one of the really important things that's stressed in the summit and in the cadaver lab in particular is the use of single-use disposable instrumentation. You use it on one patient, you throw it away, and there's no risk of transmitting diseases or infections from one patient to the other. And historically, when we were doing liposuction and fat grafting with reusable instrumentation, we were seeing a lot of horrible problems, such as mycobacterial infections, which are not even curable with antibiotics. You have to continuously surgically debride those, and it can be a nightmare for the patients and also for the doctors. So I think that's also a very exciting part, is just the introduction and being able to use these single-use disposable instruments and see how wonderfully they work. And also at the end of the procedure, you throw them in the trash can and you know that you're not going to transmit diseases or infections to other patients.
And honestly, I like the disposable better, because your staff don't have to worry about cleaning it and autoclaving it. And another thing too is that it's actually fairly inexpensive
It
to
is.
use.
It is, and it's much less expensive than an infection or a transmitted disease. Much less, and also the instruments are so fine that you can't look down the barrel of a cannula that's so fine and say, "Oh, it's completely clean on the inside." You can't see it because it's so small. The lumen is so small, so it really guarantees that you're using a brand new instrument which is completely sterilized and ready to go without having to worry about was it properly sterilized by your staff, and it's impossible to really verify that.
How is the summit different than other regenerative medicine summits?
First of all, the faculty is world class, from all over the world, and truly the experts who've published, who've written textbooks, that's a big part of it. The other thing that I think is a real plus is the content itself. So you don't have to be a plastic surgeon. You could be an interventional pain doctor, or you could do sexual wellness, or you could do hair restoration. So there's really something for everyone to learn. It's not just specifically related to orthopedics or related to plastic surgery. So the content, I think, is wonderful. The interaction between the faculty and the attendees, I think it's the most interaction that you could really find at any conference, around. And then, of course, you have the cadaver lab, which is really focused on, adipose therapeutics and the expertise that you need to have and develop using these single-use disposable instrumentation, and also just the techniques themselves. So I think all of those things just make the Regenerative Therapy Summit kind of the top of there's really no second place if you're interested in adipose therapeutics.
When the doctor attend the summit and they meet you, what type of question would you want them to ask you that will be beneficial? What I'm trying to get at is what type of essential information that you want to relay to that doctor regarding starting regenerative medicine?
The thing is that it's all varieties of questions. There are some attendees who are brand new, and they have, just very basic beginner type questions. And then all the way through to, absolute experts who are just looking to refine their techniques. There's a lot of questions on the science of regenerative therapies. There's a lot of questions on the regulation and being FDA compliant and, not going out of your lane and putting yourself and your patients at risk. A lot of questions related to the technique. And I think most importantly, we're showing outcomes. So not just what we did or why we're doing it or how we're doing it, but okay, these are the after pictures, or these are the radiographs of the orthopedic joints, or these are the radiographs of the discoloration that has gone away in the lower eyelid. So a lot of people can talk about techniques and instrumentation, but without the real detailed follow-up and outcome on these patients, you're not really getting the full stories. The questions are really from the most basic to the most complex regarding lots of different topics.
In fact, just having you talk about it, I'm excited about the summit already. It's going to be fun. We're going to be there. Dr. Miller will be there. I will be in the lab as well too. Thank you, Dr. Miller, for being on the episode with us and sharing your knowledge. And we will see you at the Regenerative Therapy Summit.
Yes, and I would have to, also thank you very much, because you've contributed a huge amount to our field. And, you're a fantastic conduit between the doctors and the patients. And I think we owe you a lot of gratitude, and it's important to not take these things for granted. So thank you for your time and your expertise and for your great contributions to the world of adipose therapeutics and regenerative medicine.
Well, thank you so much for your kind words, Randy. You always make me smile.
Mm-hmm.
And I look forward to seeing you.
Thank you, and me as well.